have multiple causes. The nowadays latest discussions about the disease have identified few well-known factors like genetics, environmental, and immune system. Basically, ulcerative colitis is a disease where there is dysregulated immune function related to the colon and some colonic bacteria, and basically the genetic and environmental factors are not indirectly the causative agents, but they can trigger the ulcerative colitis. Basically, it's immune dysregulation of the bowel function. That's why it leads to the disease. Connection and combination of three factors like environmental, autoimmune, and genetic factors are very important. Environmental factors include infectious agents. They can trigger inflammation. Any sort of infection can, bacterial infection, some viral infections can trigger the disease. Immune system, our response to environmental insult. Immune cells attack normal tissue, causing inflammation and tissue injury. Inflammatory processes can affect other parts of the body like joints, skin, eyes, oral mucosa. That's why the disease has some strong association with autoimmune diseases. Genetic mapping has identical ulcerative colitis associated genes. Genes may turn on inflammatory pathways causing ulcerative colitis. Could enable new treatments targeting inflammatory pathways signaled by specific genes, may predict course of disease and therapy. So that's the reason nowadays more work is on genetic factors, and genetic modulating agents are nowadays being practiced to treat the patients because of strong genetic association. Few genes, a lot of genes have been identified causing the ulcerative colitis and IBD. So that's why today nowadays main focus of the new modalities is on disease modifying genetic agents have been introduced to treat the disease, and they have got very good results after introduction as the new therapies for the ulcerative colitis or IBD. Symptoms, most of the patients present with diarrhea mixed with blood and mucus, abdominal pain and cramping, urgency to have bowel movement, appetite loss, fatigue, weight loss may be intermittent with flare-ups, growth impairment in children, non-intestinal complications like joint pain, skin and oral ulcerations, eye inflammation, bile duct inflammation, and other causes. All of the extraintestinal manifestations patient can have. But most common clinical presentation is the diarrhea and rectal bleeding or blood mixed with stools or mucus. Abdominal cramps, sometimes patient may not have the symptoms of abdominal cramps or urgency, but usually patient presents with the altered bowels, diarrhea and rectal bleeding. A disease pattern, rectum almost always involved, but latest guidelines they also say that 5 to 10% people can have rectal sparing. Classified by extent of area affected, patients usually report gradual onset, recurrent attacks coupled with complete remission of symptoms in the interim. Disease patterns triggers include psychological stress, we earlier discussed, NSAIDs, aspirin, ibuprofen, naproxen, appendectomy. Remission rate declines with disease severity, relapse rate higher in younger patients and can decrease with increasing age. Primarily affects quality of life, not lifespan. For disease severity, we have a lot of scores, a lot of parameters to assess the severity of the disease because it's very important. Nowadays, in the guidelines, the scores we usually follow, one is the Mayo score, then again the endoscopic assessment, we usually follow the ulcerative colitis severity index of the endoscopic severity index. So these are few scores and parameters due to which we assess the disease severity. If we generally talk about the disease severity, though, so we have the Montreal and Paris classifications. So far we follow because these classifications were very earlier classifications. So nowadays we usually follow the Mayo score, modified Mayo score, and endoscopic ulcerative colitis severity index. So in mild if the up to 4 loose stools per day may be bloody, mild abdominal pain, the disease is mild. In moderate, the frequency is 4 to 6 stools daily, moderate abdominal pain and anemia. In severe, if the stool frequency is more than 6 bloody stools, along with fewer anemia and other features. Fulminant colitis is more than 10 stools per day, continuous bleeding, abdominal pain and distension, potentially fatal. So, this is actually a general classification being practiced earlier, like mild, moderate, severe and fulminant disease according to the number of stools and rectal bleeding. The Mayo score basically discusses about the frequency of stools plus rectal bleeding plus the two other things. One is the endoscopic assessment, either it's mild, moderate or severe. Then a fourth point is the physician's global assessment, either it's a mild disease, moderate or severe disease. So this is actually modified Mayo score nowadays being practiced. Similarly, one another score is the endoscopic assessment. Endoscopic assessment score of the severity index, in which we usually see the pattern of the disease endoscopically, mucosal pattern. Either it's mild, moderate, or severe. Then what sort of bleeding is? Either it's mucosal bleeding, it's luminal, either it's obliteration, patchy obliteration. Then we see its complete extensive disease and what is the extent of the disease. So that is actually totally an endoscopic assessment. Types of ulcerative colitis, again this is a general classification. Proctitis, if limited to rectum. Proctosigmoiditis involves rectum and sigmoid colon. Left-sided colitis extends from rectum and entire left colon. Then extensive involves more than half the colon or the entire colon. This is basically actually the classification which is being practiced from very earlier ages. So still the classification is valid. This is basically Montreal classification coupled with the Paris classification. Both actually have described the left-sided colitis extensive, but one modification, the Paris classification has the pain colitis involving the, if the ulcerative colitis involves the whole rectum, it is called pain colitis, and that's severe form. There are certain extra intestinal features associated with the ulcerative colitis. The oral ulcerations, eye inflammation, they can uveitis, episcleritis, arthritis of hands and feet, lower spine, skin sores, sweet syndrome is one associated with the ulcerative colitis, joint pains. Uh, these are the extra intestinal features associated with the ulcerative colitis. Risk factors and frequency can occur at any age, often in the 30s, with a second peak in the 50s or 60s. So, mostly the disease affects the young population, affects all ethnic backgrounds, however, more common in Caucasians and Ashkenazi Jews, more common in women than men, high risk for patients with first degree relatives, parents, sibling, offspring with ulcerative colitis. Affects 35 to 100 people per 100,000, estimated 700,000 in US with ulcerative colitis. So in United States, the ulcerative colitis is very much common, but Crohn's disease is also more common compared to Asian countries. Colorectal cancer risk is ulcerative colitis. We earlier discussed a high risk factor for colorectal cancer increases after 8 to 10 years from ulcerative colitis onset. More common as severity of ulcerative colitis increases. Screening colonoscopy is recommended for ulcerative colitis patients. Usually, the risk of ulcerative colitis, colorectal cancer is more high in the patients having extensive disease, like severe disease, or the patients who didn't follow up regularly or are not compatible with the treatment. So the risk increases day by day with increasing severity. So that's why it's very important to do the screening colonoscopies for the ulcerative colitis patients. We see a lot of patients here, they didn't come in follow-ups. They lost even years to come for screening colonoscopies. That's why they didn't know about the severity of the disease, and the disease gets worse day by day, and ultimately they land into the surgery or develop the colorectal cancer. So that's why screening, colonoscopy plus counseling of the patient is very important. We can see this is the ulcerative, the picture on extreme left is ulcerative colitis, then the associated with abdominal abnormal growth, and ultimately can develop the colonic cancer. Common tests to diagnose and maintain ulcerative colitis. Diagnostic tests: fecal sample, presence of bacteria, parasites for any bacterial infections. Any patient with suspicion of ulcerative colitis, we must do the blood stool cultures plus the cultures for C. diff toxin is very important before we diagnose the ulcerative colitis. Blood samples for any infection, anemia, inflammatory markers, biopsy of intestinal lining. The biopsy rule is to take the two samples from the 5 different areas, from rectum to the colon. And one very important thing that associated with ulcerative colitis, there is landmark cutoff sign between a normal and abnormal mucosa in ulcerative colitis usually. So this is one endoscopic landmark. Liver and kidney function tests. Endoscopy is the gold standard for ulcerative colitis diagnosis. Flexible scope inserted into the rectum. Sigmoidoscope examines lower third of colon. Colonoscope examines entire colon. Another strong recommendation in latest guidelines is that uh, if you suspect any patient of having ulcerative colitis, then you must do the entire ileocolonoscopy to rule out the uh, other causes plus Crohn's disease. Visual examination, radiographs, image shows constrictions, barium enema, a CT scan provides more detail than X-ray. So these are the helping tests like X-ray abdomen, but it's not diagnostic. For any sort of constrictions, strictures, or any dilatation, we can take the help of the radiograph, abdominal X-rays. Barium enema is not very much supportive or helpful in majority of the cases. CT scan sometimes can give some clues towards the diagnosis or to rule out some complications related to the ulcerative colitis. Uh, Treatment options: we have the once the patient diagnosed with the ulcerative colitis, the next is to focus on the goal of the therapy. What is the goal of the therapy? Basically, our goal of the therapy in ulcerative colitis is to achieve the maintenance and to acquire the mucosal healing and further stop the progression of the disease towards the towards the colorectal cancer. We have the anti-inflammatory drugs, aminosalicylates, 5-ASA agents, very well known to all so far. Corticosteroids, we have prednisolone and hydrocortisone, and immunosuppressants, azathioprine, cyclosporine, methotrexate, and few biological therapy agents nowadays blocks inflammatory pathways like infliximab and few other more drugs, antibiotics to treat infections. So these are basically the overview of the drugs. So how to use these drugs and what are the recommendations? These are very long, lengthy guidelines. So today we will just focus on the drugs, generally which drugs we can use, and about this corticosteroids like prednisolone and hydrocortisone. We have other options like budesonide and some other steroids, because we can't administer the steroids for maintaining and for maintenance, but just only to acquire the remission, and for the limited time period we can offer the steroids. We have the options of corticosteroid enemas and 5-ASA enemas. So it needs another day for the discussion of the treatment, because a lot of guidelines have changed the treatment options. A lot of new drugs have been introduced. So today we will just give a brief overview of about the drugs. So in new drugs have been introduced. Lot of new drugs have been introduced, like we call them biological agents, yeah, some immunomodulator agents. One drug mentioned here is infliximab. Beside this, we have a lot of other drugs like vedolizumab, adalimumab, and a lot of other drugs, ustekinumab, and some other new drugs under trial. Antibiotics to treat infections. If we suspect any infections, then we have the options to give the antibiotics to the patient. Location is very important because rectum often responsible for most nagging symptoms, frequency, urgency, nighttime BMs and tinnitus. So these features we have to keep in mind before we diagnose the patient with ulcerative colitis. Rectal therapy can minimize these symptoms. Like I discussed this, we have the options of, if the disease is limited to rectum, is called as the proctitis, sigmoidoproctitis. Then we have the options of enemas, steroid enemas, and then we have the 5-ASA enemas, suppositories, and in shape of foams nowadays available. Uh, Surgery is the option for ulcerative colitis patients who don't respond to medications, usually 25 to 40% of cases. But nowadays, this percentage is a little bit decreased because of good medications available nowadays, especially after the introduction of the immunomodulators and biological agents. The incidence has decreased. Earlier, it was more than 40%, but now it's less than 25%. But still they say that the patients, one third of the patients who even have been put on new drugs, new biological agents, they ultimately land to the surgery. So still the incidence is very high. Consider a cure for ulcerative colitis. Possible approaches, we have the proctocolectomy, removal of entire colon, small intestine brought to abdominal wall. Patient wears an appliance to catch waste, J-pouch. Ileoanal anastomosis, newer approach, preserves normal bowel function. uh, Creates intestinal pouch from. So these are basically surgical options for the patients who ultimately, the 25 to 30% of the patients who ultimately land to the surgeons. The treatment strategies, we have the primary goal of medical treatment is the remission, prevention of the recurrence, control impact of complications, maximize quality of life. So this is the main focus of treatment, basically to achieve good remission, uh, prevent the further recurrence and further complications. Treatment strategies, we have the monotherapy, single medication treatment. If the patient has mild disease, we can usually recommend single medication treatment. Combination therapy is usually recommended for the patients who didn't respond usually to single therapy. So we couple the another agent like immunomodulator agent or any drug like azathioprine. Multiple medication treatments, we have the choice of strategy depending on disease severity and patient's consideration. So this treatment strategy actually relates to each individual patient, whether to start single therapy and when to start the combination therapy, and when to refer the patient to the surgeon, and when to start patient an immunomodulator agent or another drug. So this all depends on the choice of physician and severity of the disease plus response of the patient. So it varies for each individual patient. But again, disease severity is very important, and we only can assess the disease severity after clinical assessment and endoscopic assessment. So we can get the idea whether the patient is responding or not. Response to medication again is very important. Prolonged maintenance, possible side effects. So this is the most important factor we earlier discussed. Most of the patients lost maintenance because of the prolonged therapy, and a lot of drugs have side effects, we all know. So that's why patients usually quit the therapy and they get into trouble, because this is very miserable and long relapsing and remitting disease. That's why these factors are associated with the treatment. Common questions: when should I see a response to these medications? So this is very, again, very important point to ask, uh, when we should see a response to the medication. Treatment strategies, top-down strategy. We have the early aggressive use of infliximab as initial treatment, induces rapid clinical response, may enhance quality of life. Infliximab we earlier discussed, anti-TNF agent, very effective, and this was the first drug to introduced as anti-TNF, so has very good results. So far, the drug is being used. Its use is basically very aggressive sometimes, because its IV dosage is for weeks, and the patient responds very well and having less side effects compared to other oral drugs. Bottom of strategy is standards, sequential treatment for remission and maintenance, cost effective, minimal side effects. So basically, these agents, the new drugs like infliximab, vedolizumab, these are the drugs uh, got very aggressive and very active results, but quite expensive and not available in most of the drugs are not available here. So that's why we didn't use. But the areas where the drug is available, they have got very quick results, and they are not very cumbersome to the patient to take, because they have the IV dosages and the dosages in weeks, so they can easily use these therapies. Ulcerative colitis impact on quality of life. We all know it's a practical consequences of ulcerative colitis flare up. Unpredictable episodes of diarrhea, bleeding, cramping, sudden urgency to use restroom, temptation to avoid travel or activities. So, I earlier discussed this disease has a very strong psychosocial effect on the life of a patient. And another important thing is that most of the patients suffering from ulcerative colitis, they are quite young patients, especially the female population. They are quite young, and obviously they have a lot of social issues to address the disease, and a lot of patients even hide the disease because of some stigmata, social stigmata. We all know, especially female population who come to us, so they are very depressed actually, and a lot of the females have some infertility issues, and they usually hide the disease. So these are the factors that definitely interfere the quality of life, and very encouraging and very positive counseling is needed for these patients to cope with the disease, because it's a lifelong debility and remitting and relapsing disease. Medication adherence again important, decreased chance to flare, increased chance of obtaining remission. Prospective study in patients with ulcerative colitis in remission and taking mesalamine found chance of remission was 89% in adherent patients, 39% in non-adherent patients. Colorectal cancer prevention, possibly 5 ASAs. So medication adherence is again very important to address, because a lot of patients have no idea about the impact of the disease. So we have to counsel them about the proper and regular use of the medications. Ulcerative colitis impact on quality of long-term medications like methotrexate. Side effects, we all know, is liver cirrhosis, low white blood cell count, inflammation of the lungs, plus renal nephrotoxicity. Cyclosporine is notorious for its renal toxicity. That's why we usually recommend in severe cases and in any hospitalized setup. Steroids, not for maintenance treatment. We earlier discussed side effects all associated with the steroids. Antidiarrheals increase risk of toxic megacolon. Antidiarrheals are not very much recommended, but in some cases, if the episodes are more than 5 to 10, we usually recommend. NSAIDs, aspirin, these are drugs likely to make symptoms worse even short term. So these are the drugs that we usually avoid in ulcerative colitis. Managing a chronic illness is very important to focus on. Advanced planning is very important about the medications, personal supplies, bathroom locations, overcoming fear of being in public, ileostomy patients, maintaining social interaction to enhance self-image. So these are the factors we need to discuss, and we need to counsel the patients about the. These are actually the facilities we can provide, but these are not obviously possible in our setup. In advanced countries, they have made our own societies, ulcerative colitis and Crohn's societies like celiac disease. So they have in a pool socially, and they interact with each other, and they have the awareness sessions. But unfortunately, we don't have the such sort of facilities here. Uh, Exercising with ulcerative colitis helps maintain weight and well-being, reduces stress. Things to emphasize: consider low-impact activities, yoga, swimming, golf, bowling, walk instead of run, plain bathroom breaks, listen to your body, like don't needlessly overdo, consult your physician, exercise between flare-ups. So these are all the factors we can aware patient about. Usually patient didn't consider the positive things. They have most of the times they get some negative impact of the disease, so we have to counsel them that they can have the normal life spends. So all the things they have mentioned we can aware the patient about. Again, the very important thing is the stress. We need to avoid the stress in the patient, because stress is the factor that can trigger the disease. Role of diet in managing ulcerative colitis again is very important, because of the relapsing nature. The patient, most of the patients with ulcerative colitis, they are suffering from malnutrition, some vitamin deficiencies, and they have anemia and other associated symptoms. That's why a dietary role is very important. Link between diet and flare-ups not established. Avoid foods that aggravate symptoms. Limit dairy products if lactose intolerance. Experiment with the fiber. Eat several smaller meals instead of three large ones. Drink ample fluids. Consider nutritional supplements and consider probiotics. The role of probiotics is again controversial, but some studies are in favor of the probiotics, but their role as treating ulcerative colitis is not decisive, but as a supportive and adaptive therapy to patients with ulcerative colitis, the role of probiotics is good, we can offer. Uh, CCFA coping resources. This is actually the society working in the United States, so it's not related to our part. Strengthen communication with your doctor. Questions to ask your doctor: what parts of bowel are affected? What treatment plan is suitable for me? What you recommend probiotics? Would you recommend probiotics? What side effects from medication maker? How soon do symptoms subside? Should I change my diet or take supplements? Are there any questions on my restrictions on my activities? How often do I need a follow-up colonoscopy? So these are the questions usually patients ask from the physician about the disease extent, about the priorities, about the medication. But usually the patients who are well aware of the disease, they usually put these questions. But most of the patients who didn't know about the disease, definitely they don't ask any question from the physician. But the physician must aware and educate the patient about the disease, its severity, especially adherence to the medication. It's very important. So I think this was the last slide from the presentation. It was actually a brief overview of the ulcerative colitis, and कुछ मोटी मोटी चीज़ें मैंने बताई है इसमें, क्योंकि डिटेल जो मेडिकेशंस हैं इसकी बहुत इंपॉर्टेंट है। उस पर मेरे ख्याल से हम किसी दिन फिर कोई एक सेशन रखेंगे, क्योंकि उसमें बहुत सारे ड्रग्स हैं, उसकी डोसेजेस है और उसकी रिकमेंडेशंस हैं। हम तो अभी तक यहाँ पे जो है वो 5 ऐसे ही देते हैं, जैसे में सकोल है, या जो वो है साथ में एजिथाइप्रिन है, इमरान वगैरह हम दे देते हैं स्टीराइड्स के साथ। बट अदर लॉट ऑफ ड्रग्स जैसे अल्फा TNF है और बायोलॉजिकल एजेंट्स है,